Now we'll be coming to our first topic, that is the storage diseases. Now, why are they called as storage diseases? Because actually the problem is enzymatic. This results to actually accumulation of certain types of substances such as glycosaminoglycans, chondroitin sulfate, and such. That's why these, when accumulated in the joint, they form a kind of a storage disorder, which is briefly covered under the umbrella of storage disorders, which is mainly include multiple disorders such as 5 to 6 types of mucopolysaccharidoses and Gaucher's disease. We'll be in this section, we'll be going through what are the different types of mucopolysaccharidoses, what it is actually a mucopolysaccharidosis, and how we can manage mucopolysaccharidosis and Gaucher's disease. So finally, coming to the mucopolysaccharidosis, it's actually there's not just one disorder. It's a group of storage disorders which is characterized by absence or defect of lysosomal enzymes that are responsible for the breakdown of glycosaminoglycans. So if this enzyme won't be present, what would this result in? That would result in accumulation of glycosaminoglycans in the joints and would produce a characteristic skeletal abnormalities which can be seen in the patients with these disorders. Usually glycosaminoglycans accumulation leads to skeletal abnormalities. There are almost 6 different types of glycosaminoglycans disorders which are briefly covered in the umbrella of mucopolysaccharidosis. This type 1 is called as Hiller syndrome or type 1 mucopolysaccharidosis. Type 2 is the Hunter type mucopolysaccharidosis. Type 3 is Sanfilippo type. Type 4 is Morquio-Bressel type. Type 5 is She syndrome, and type 6 is Morteaux-Lamy syndrome. Out of these two, the type 1, type 2, they're usually more common, and especially the type 2, the Hunter syndromes, and we will briefly discussing the these each and every type briefly, and then we will be going to the treatment of these diseases later on. Coming to the clinical syndrome, usually Hunter is X-linked recessive, that is usually the males are only affected and females are the only carrier, while other types, almost from 1 and 3, 4, 5 and 6 types, are all autosomal recessive pattern. That is, both the females and males can be affected. Usually the features, the first and foremost is actually associated with short stature. The second is in coarse facial features and thick inelastic skin, especially with the Hunter type 2 mucopolysaccharidosis. Then they are associated maybe hepatosplenomegaly. There may be associated neurological abnormalities. These patient may have mental retardation as well. And then spinal abnormalities, especially of the cervical spine. These patients usually have associated atlantar axial instability. Now coming to the type 1, which is actually autosomal recessive. These types include heterogeneous condition. It's alpha L irodinase deficiency. As I just told you briefly, this is actually enzymatic deficiency of some kind of an enzymes which are mainly present in the lysosomes. In Haller type 1, it's alpha L irodinase deficiency, which produces actually results in accumulation of heparan and dermatan sulfate, which this usually a condition, although it's a very rare condition, but is characterized by slow mental development, and other features actually include severe joint stiffness. Why? Because heparan and dermatan sulfates get accumulated in the joints. This is coxa valga, that is, there is increased neck shaft angle. Then there is femoral head irregularities and genovalgum, that is usually produces a specialized knocked knees, and femoral head irregularities because accumulation in the hip joint, knee joint. When this gets these heparan and dermatan sulfate gets accumulated in spine, this usually results in kyphosis and thoracolumbar gibbous, which is hyperkyphotic deformity of thoracolumbar spine. And usually mucopolysaccharidosis, odontoid hypoplasia may be associated in these conditions as well. Macroglassia and hearing loss, and cardiorespiratory insufficiency. Now coming to the Hunter type mucopolysaccharidose, I just told you that it is actually X-linked recessive. That is, the most affected area is usually the children, the male children, and the mothers are usually the carriers. It's iduronate sulfatase deficiency, which actually results in heparan and dermatan sulfate accumulation, It, as it is X-linked recessive, so occurs in males only. Its features include some of them mimic the other types, and some of things are different from the other types as well. As what mimics the Hewler type 1 is macrocephaly and coarse facial features, joint contraction and stiffness, hip arthritis may be present as well, and cardiorespiratory compromise as well. But once the diagnosis is actually made on the type of enzyme which is deficient. Other types, as just told you, that there are not only one or two types, there are four, three, four, five, and six types actually. The third type is actually Sanfilippo type mucopolysaccharidosis. Usually, it's a deficiency of heparan sulfamidase deficiency, which leads to heparan sulfate accumulation. Usually, intellectual impairment and slow growth and stunted growth is a classical feature of this disease. While the fourth type, which is Morque Bruspol type, in which there is actually beta glucosidase deficiency, there is normal face and intellect, usually the coarse features and neurological abnormality is absent, while limb and spinal anomalies such as actually short stature, skeletal dysplasias, and thoracolumbar kyphosis is classically present in and more pronounced in type 4. In type 5, which is called as She syndrome, usually reclassified as subtype of MS type 1. Why? Because initially it was thought to be another type, but now it's called as, it's a kind of a subtype of Hewler syndrome in which there is alpha L iodinase deficiency. Coming to the last sixth type, that is the Marfan syndrome. This is usually characterized as, it's a polysaccharidosis, so it's a subtype. It would definitely be, and there will be absence of some kind of enzyme, and the enzyme in this case is N-acetylgalactosamine 4-sulfatase deficiency, which results in accumulation of dermatan sulfate. Although it's almost similar to the type 1, but usually the features are more mild. And for example, the features include front bossing, gross facial features, then kyphosis, neurological abnormalities, LVS, short stature. Now, the management is actually based not on depending upon the kind of enzyme deficiency it is. It's actually giving those enzymes would result in normal skeletal development. But mostly the management is directed against the managing the complication, not exactly the enzymatic deficiency. For example, once accurate biochemical diagnosis has been made, we have to predict the prognosis and we have to give them the enzymes. But certainly, in some cases, that for example, if the neurological damage has already occurred, that is not reversible. So we have to consult the patient regarding the neurological abnormalities as well. The enzyme replacement therapy is a therapy of choice. If that enzyme is deficient, you have to give them, but it's not always the case sometimes. It's just the complications you have to manage. Other options which have been routinely investigated now is the bone marrow transplant, umbilical cord blunt transplantation, and corneal transplantation. Sometimes this transplantation has has actually improved the prognosis of these diseases. But for example, if the joint abnormality has occurred, then you have to treat as if it's case of genovalgum or genovarum. If it's a thoracolumbar spine kyphosis, may have to fuse the spine. And then depending upon the kind of a problem which has occurred, this orthopedic intervention depends upon the managing the abnormalities. While the medical side, or let's say pharmacological side of the diseases, are actually can be managed by replacing the kind of enzyme which is deficient. Now, as I told you, different modalities of treatment are, sometimes we are just managing the complications, other times we are actually replacing the enzymes. Management may be, overall, the general management includes removal of tonsils and adenoids, correcting spinal deformities such as by using either anterior or posterior fusion techniques. In hip and knee, if it is advanced osteoarthritis which has already occurred, you may need replacements in form of TKR and THR. Surgical stabilization of spine may also be needed, and if the joints have resulted in a contracture, then surgical release of these contractures may also be required. Coming to the next disease, which is another form of a storage disease, and why they are called a storage disease, because this enzymatic deficiency leads to accumulation of these glycosaminoglycans in the cells. That's why they are called as storage diseases. Gaucher disease is autosomal recessive, like other types of mucopolysaccharidoses except type 2. It usually results in mutation of glucose cerebrosidase gene, which is actually codes for glucose cerebrosidase enzymes. And once if that enzyme is deficient, this results in accumulation of these glycosaminoglycans in the cells. Especially, the features include hepatosplenomegaly and pancytopenia, stiff joints and osteopenia, osteonecrosis of bone and bone crisis and chronic pain. What actually results in usually these bone pains are actually mainly due to avascular necrosis of the hip joint, especially when these patients are usually more prone to infections, and during infection there may be increased bone pains and increased bony necrosis, therefore resulting in bone crisis. Then we pyrexia and leukocytosis. Although the cells are in leukocytes are increased in number than normal, but as they are defective because they cannot carry out their function, therefore these patients usually are more prone to infections and increased chances of pyrexia in them. Usually the organs which are affected are mainly hepatosplenomegaly, that is the liver and spleen, and the brain mainly. Treatment is actually enzyme replacement. You have to replace this enzyme in glucose cerebrosidase. Coming to the radiological features, which would show that most likely this child is actually suffering from Gaucher's disease. These radiological features may include patchy radiolucencies in the foot and ankle, Alzheimer flask appearance. If you appreciate over here, this is the classical appearance of a due to femoral condyle hypoplasias. There's usually the distal femur, they appear almost like a Alzheimer flasks in which was used in the 19th century. Now they may simply present with femoral head osteonecrosis, that there may be associated bilateral AVN of the hip joint, are associated fractures. Sometimes once the fracture is investigated, because the child is of short stature, and there may be associated skin pigmentation disorders, or maybe then once the more and more is investigated, it's the underlying problem is actually that the bone is dysplastic, and therefore due to these storage diseases, and this cannot carry out its normal function. As a result, these bones are usually more prone to fractures, resulting in increased chances of fractures. This section we have covered the two types of storage diseases. One is the mucopolysaccharidosis and the second is the Gaucher's disease. The most importantly, there are different types of enzymes which may be deficient and which actually leads to glycosaminoglycans accumulation in the cell. That's why they are broadly termed as storage diseases. The main aim of therapy should be the enzyme replacement which is deficient, and from orthopedic point of view we have to manage the complications most of the time. Thank you very much. Keep watching sqadia.com.